Hello everyone, it's Kelly and I'm here to discuss barriers to advanced practice nursing. Now, who are APRNs? APRN stands for Advanced Practice Registered Nurse. According to the NCSBN, APRNs are prepared by education and certification to assess, diagnose, manage patient problems, order tests, and prescribe medications. They are either master or doctor prepared registered nurses and hold national board certification and state licensure. Under this umbrella term of APRN, there are nurse practitioners, nurse anesthetists, nurse midwives, and clinical nurse specialists. So, what is the problem? Well, there are several barriers in place that prohibit APRNs from practicing within their scope of practice independently. The barriers that will be discussed in this presentation today will be regarding regulatory barriers, specifically state and federal regulations. So what? Why should we care? Identification and mitigation of these barriers will drive conversations that will emphasize the importance of the APRN for the overall health of the American population. In the coming decades, it is projected that individuals above 65 years old will creep up to 25% of our population. Specifically, I want to point out that in 2030, the older adult population will jump from 17% to 21%, with 73.1 million older adults. As they age, there will be an increase in the need for health services. Additionally, the need for more medical providers also increases. This is an issue because by 2034, it is projected by the Association of American Medical Colleges that there will be a shortage of physicians between 37,800 and 124,000. In primary care, up to 48,000, and other subspecialties that include OBGYNs up to 30,200, and other subspecialty that includes anesthesiology, there will be a shortage of up to 35,600. According to the United States Bureau of Labor Statistics, between 2020 and 2030, the number of APRNs in the workforce is projected to grow by 45%, above the average compared to other occupations. Similarly, as discussed in the previous slide, the growth in jobs for healthcare diagnosing and treating professions will only increase by 12%. According to the American Association of Nurse Practitioners, APRNs are listed as one of the most in-demand health professionals of the next decade. Although the number of APRNs is increasing, their practice is limited by federal and state law regulations. The Future of Nursing 2020-2030, Charting a Path to Achieve Health Equity, urges primary care practices to expand the role of RNs in providing primary care services and allow them to practice to the full extent of their education and training. Restricting APRN's practices will only exacerbate the issue of health inequity across the United States. Removing federal and state restrictions would allow APRNs to practice independently while increasing healthcare access, quality, and equity. Although all APRNs share the same national certification, their scope of practice varies from state to state. The independent and full scope of practice by APRNs is not accepted by the entirety of the United States of America. Some states adopt full practice, reduced practice, or restricted practice authority. Although full practice authority states permit APRNs to practice independently, some organizations and third-party payers will create restrictions on their practice. Reduced practice authority states require collaboration with a physician, whereas in restricted practice authority states, supervision is required. Full practice authority is considered independent, while reduced and restricted practice is considered not independent because they require collaboration with or supervision by physicians. Independent practice for nurse practitioners vary from state to state. As of today, 26 states, including Washington, D.C., grant full practice authority to NPs. Most recently, as of 2022, New York NPs are now practicing with full practice authority, and as of April 2022, Kansas has joined as well, making it the 26th state to join. Independent practice for CRNAs also vary. Currently, 30 states, including Washington, D.C., allow independent practice for CRNAs. Stephanie Grolmund, president of the New York State Association of Nurse Anesthetists, stated that they are currently working on being recognized and licensed as a CRNA in New York State, instead of practicing under their RN license. According to the American College of Nurse Midwives, currently there are 27 states, including Washington, D.C., that allow nurse midwives to practice to the full extent of their education, clinical training, and certification. 3 states still require physician supervision, and the remaining 20 states require a signed collaborative practice agreement with a supervising physician. In 28 states, clinical nurse specialists have independent practice authority. 13 of them recognize clinical nurse specialists as advanced practice registered nurses but require them to have a collaborative practice agreement with a physician. However, the remaining states do not recognize clinical nurse specialists as APRNs. Currently, there is no uniform model of regulation for APRNs across the states. Each state determines the APRN scope of practice. This significant barrier for APRNs decreases access to care for patients. The consensus model, according to the NCSBN, provides guidance for states to adopt uniform regulation of APRN roles, licensure, accreditation, certification, and education across the United States. Adoption of the consensus model moves states towards uniformity and license portability. However, implementation among states has been inconsistent. The map on the right is an overview of each state's consensus model implementation status. The darkest shade of green on the map shows the states that follow the consensus model up to 100%. These are the states that allow full scope of practice for APRNs. Some federal regulations impede APRNs from practicing fully. For example, the Balanced Budget Act of 1997 gives states the option to recognize nurse practitioners and certified nurse midwives as primary care providers. However, states are not required to do so according to the American Nurses Association. In addition, federal legislation does not list APRNs as Medicare and Medicaid eligible providers on their websites. This disadvantage limits the American population's access to APRNs when selecting providers. Furthermore, although APRNs can be directly reimbursed by Medicare, the vagueness of some legislation may complicate the APRN's full practice authority in hospitals. The prime example of this is the Social Security Act of 1965. In 1997, the Healthcare Financing Administration proposed regulations for hospitals' participations in Medicare. This regulation states that a patient under Medicare must be under the care of a physician. Because nurse practitioners are non-physicians, hospitals must place nurse practitioners in collaboration with physicians to receive full reimbursement. This allows Medicare participating hospitals to restrict nurse practitioners from practicing fully, even though they are in FPA states. If APRNs could be named under reimbursable main providers under Medicare, this would allow them to work independently in hospitals. Lastly, in other practice settings, APRNs are permitted to bill their services that are authorized by state law directly to Medicare. However, Medicare will only pay 85% of the physician's fee. Interestingly, if the APRN bills in collaboration with the physician, reimbursement is at 100%. Changes in federal legislation regarding Medicare could help APRNs practice fully and independently. I am choosing to present 2 particular studies that will identify the barriers and share some guidance as to how we should tackle the barriers. This first study by Shorn et al. In 2022, called Results of National Survey, Ongoing Barriers to APRN Practice in the United States, focuses on practice barriers identified by APRNs across the country, regardless of practice authority, APRN type, area of practice, and nature of practice. They surveyed 7,496 APRNs on what their perceived barriers were. They found that licensure and administrative issues was the most commonly reported issue amongst all barriers. Interestingly, even in full practice states, these were still found to be an issue. There are other barriers that were identified, and these are the ones listed below. It is interesting to note that all of these barriers are related to regulations specifically, except for collegiality. One of the interesting facts is that 40% of all APRNs identified that restrictions for home health approval and the requirement for a physician's signature for medical supply orders was also one of the most commonly encountered regulatory barriers. The second study by Kleinpel et al. 2022, called Breaking Down Institutional Barriers to Advanced Practice Registered Nurse Practice, identifies similar barriers to the first study, but shares some recommendations as to how nurse leaders will play an important role in addressing these issues. They recommend that nurse leaders should identify the existing institutional barriers to APRN practice, actively support and target the removal of these barriers, and also implement the consensus model and the regulation of APRNs in their respective institutions. In addition, it is important for nurse leaders to be knowledgeable about APRN practice within their specific state. This will allow engaged involvement in state and national organizations positioned to make policy changes impacting APRN practice. Overall, both of these studies highlight important facts and identified several regulatory barriers that impact not only APRN practice, but also healthcare for the United States population. I believe that the first step is to make all states full practice states and then eliminate the barriers that prevent APRNs and FPA states from practicing fully. If APRNs could practice to the full extent of their training and national certification, according to Kleinfeld et al., the national primary care shortage would decline by 70%. Lastly, it is very important to recognize that nurse leaders do play an important role in eliminating barriers to practice for APRNs. I believe that there should be more studies regarding the comprehensive APRN scope of practice. In my current research in discussing APRN roles, many studies primarily focus on nurse practitioners' scope of practice. Some researchers even use them synonymously. Further studies need to be done to discuss barriers of nurse midwives, nurse anesthetists, and clinical nurse specialists. Furthermore, it would be very interesting to see more studies relating the effects of the COVID-19 pandemic on the perceptions of our governing bodies and legislators regarding APRN practice. For the states who lifted practice authority restrictions, it would be very interesting to see their reasons as to why they are reverting back to reduced practice or restricted practice authority. All of these will hopefully spark more meaningful discussions regarding policy changes and actually create some changes. Eliminating state and federal regulatory barriers for APRNs to practice independently will improve health equity across the country. Additionally, this will also address the current and projected physician shortage that we are already facing and will face. In general, being aware of these barriers will hopefully spark conversations and propel policy changes to occur in legislation and regulation by our governing bodies.